So it's just after 10:30. So we just make a start, Jane. Is that okay? I think there's a few people joining, but
yeah, that's great.
Is that okay? Right. Okay. Well, look. Thank you very much, everybody, for joining this morning. This is an absolutely amazing attendance at this training seminar. So this is around lifestyle modification and behavioral interventions for prevention of disease. And this is part of our P4 seminar series through the Biomedical Research Centre. And a big thanks to Jane Crosby and Georgina for helping organise this and pull this together, and for all the speakers that you're going to hear today. This is a really, really important area, and we've got some really, really good speakers who are going to talk about ongoing research in this area. My job is really to give you a bit of an update on the Biomedical Research Centre and where we're up to with that. So as you know, we're now into our, we're just about to enter our 5th year come April. And this past 12 months has been unprecedented and extraordinary as the pandemic has sort of evolved around us, and we've had wave after wave of infection going around the community. And I think it's probably worth just first of all recording my thanks to everybody in the BRC who's really, really stood up and helped address some of the issues and challenges that we've had in Manchester throughout the pandemic. That includes people who have gone back into clinical practice and sort of helped on the front line on wards, particularly our respiratory team have really been working hard on the front line and intensive care, respiratory wards, etc., working on this. We've had a lot of our researchers who have pivoted their research really, really quickly to address issues in COVID across the spectrum, from hearing and deafness to cancer to rheumatic diseases, etc. We've been involved in trials and vaccine studies and things, and people have really worked hard on that. And there's a real testimony to the flexibility of our workforce that we've been able to sort of contribute to that Greater Manchester response. So a big thank you to everybody. And there's an awful lot of people like project managers and research assistants and things who have done their bit as well, whether it's working down at the Lighthouse laboratories, whether it's organising and helping with data entry, etc. So it's a huge effort across the board. So I just want to thank everybody for all their hard work. We're now in a situation where, because of the pandemic, there's been a delay in the new competition being announced. And so instead of a new competition being sort of active at the moment with a view to us starting in April 2022 with our next BRC, it's been sort of pushed back a little bit. So the competition will start fairly soon, and the next BRC will start in November 2022, all things being equal. So we're going to be starting a process of, we've already started a process of trying to work out what themes will be in the next BRC, what the next BRC is going to look like, what our strategy will be. And so we've put out questionnaires to various groups, and we're going to be pulling those all together to try and get the best configuration for the next BRC. So it's a huge amount of work over the next 8 or 9 months, and we'll be calling on many people on this on this meeting today to sort of help with that and chip in and sort of help develop and build a strategy. But today we're going to talk about lifestyle and how that influences disease, etiology and pathogenesis and outcomes of disease. And I was just sort of thinking about some patients, I work in rheumatology, so we see people with arthritis a lot. And even within that, there are very clear classic lifestyle exposures that that increase the risk of certain conditions. So alcohol is very, very strongly associated with gout, which is probably one of the more curable forms of arthritis. Cigarette smoking, we know, actually, we all know about cigarette smoking and heart disease and cancer, etc. But probably if nobody smoked cigarettes, there would be about 20% less rheumatoid arthritis nationally, because we know that cigarette smoking drives and is a causative factor in rheumatoid arthritis development. When we think about obesity-related illnesses, rheumatology clinics are full of people where obesity has been a major driver of their disease, whether that is gout, whether that's osteoarthritis, etc. And then, of course, one of the modern pandemics in Manchester is cocaine use. And one of my areas of interest is systemic vasculitis, and a number of our patients with vasculitis actually who often come with resistant disease, in other words, disease that doesn't respond to our classic therapies. And you ask the question about their cocaine habit, and you realize it actually has been driven by use of cocaine. And so this is one of our sort of early history taking has now evolved into thinking about lifestyle. But then lifestyle goes beyond those classic associations, which are often easy to pick out. And you get into this much more complex world of health beliefs and health behaviors and cultural factors that drive that, and how we think about our health, how we think about the doctor-patient relationship, and the importance of lifestyle to our general health. And so I think what we're going to hear today is a number of researchers who've been really looking at many of these areas over the past few years. And you're going to hear about some obvious associations, but then you're going to see something about the complexity of changing health behaviors, changing health and lifestyle, and how that comes into their fundamental belief systems that many people have and carry with them. So without further ado, I'm going to hand over to George, who will introduce the program for today. But as I say, thank you all very much for your efforts over the last 12 months during the COVID crisis. It's ongoing, and we're going to be calling on you time and time again to help with that. But for today, we can focus on lifestyle and behavior, and we can think about how we can help to prevent disease, because the benefits of some of these interventions are going to be multifaceted in reducing the burden of disease in our community. So thank you very much.
Thanks, Ian, for the BRC update and introducing, I think, the area that we're going to talk about today. So again, I'd like to echo my thanks to everybody that's joined today, and we'll listen to a series of talks by numerous people who are sitting in research themes of the BRC. Today's been a real opportunity, actually, just to say a little more about the BRC in terms of its training. So I'm just going to share my screen. Jane, can you see my screen?
Yeah, that's great. Thanks.
Okay, so today we're going to, as Ian has said, we're going to focus on lifestyle interventions. But this is really part of a much bigger series, which is our P4 themed discussion and networking events. And these have been really the core of the training at the BRC, so participatory, predictive, prevention and personalised. And throughout the year, you will see a number of these events that we will host. Earlier or later last year, we focused on being predictive and looking at AI, but like today is focusing on the preventative. So do keep an eye out for these networking events, because the aim is to bring people together to form a community, but also to learn more about the research that is going on in each of the 4 areas. So the aims and objectives for today, really what we'd like you to get out of today is to discuss and to develop an understanding around lifestyle interventions that are influencing disease. And in particular, I think the talks that we have today will demonstrate, I guess, the importance of these lifestyle interventions. In a particular of interest of mine is understanding the psychology behind the behavioural change and how best to implement those lifestyle interventions and get them adopted. My background is biohealth informatics, so I do something similar with digital interventions. And then discovering some of the preventative research and action being taken in Manchester, and identifying the key contacts should you wish to take anything forward. So we've got a fantastic session outlined today. We've got 5 key speakers who are going to give you their view on, talk about lifestyle interventions from cancer, dermatology, hearing health, musculoskeletal and respiratory diseases. And at 11:30 we're going to have a short break, so you can have a short walk round and grab a cup of tea. It's towards the end that we're going to take and have a final panel discussion. So we'll take your Q&As, questions, and be able to address those. Meanwhile, though, if you have any questions that crop up during the talks, can you please put them in the chat? Jane has highlighted that you are able to do that. And then we will either, the speakers will either come to them as they finish their talk whilst others are speaking, or we will bring them up at that final session. I'm just going to do a final reminder that if you're not speaking, could you please be on mute? And have your camera switched off so that we can focus just on the speaker, and that will be great. And hopefully you'll have an enjoyable session with the speakers. So it's with great pleasure that I'm first of all going to introduce, sorry, just stop sharing, Michelle Harvey, and she's going to speak to us about a prevention of obesity related to cancer. Michelle?
Okay. Can you see my slides?
Yes, that's fine. That's great, Michelle. Thank you.
Hang on, let me just. Can't see me. Hang on, sorry. You can't see me, can you?
No, but if you've started your video, then people will be able to see. Yes,
okay,
there you are. Fantastic, Michelle.
I probably didn't want to, but there you go. Right. Okay. So thank you so much for giving me the opportunity to talk about our research on preventing obesity-related cancers. I'm Michelle Harvey. I'm a research dietitian based at the Nightingale Centre at Wythenshawe Hospital, with particular interest in preventing breast cancer, and I've been working in this field for about 20 years. So I'm going to, in my presentation, in my 15 minutes, I'm going to whiz through some of our achievements in that period of time, and particularly focus on those that we've been able to do with the support of the BRC, as you were just hearing, over the last four years. So obesity and overweight are linked, have established links to about 13 types of cancer, which are shown on this slide. Sorry. Okay. The strongest links are probably actually with cancer of the womb, which has if you're obese versus being a healthy weight, you have a fourfold risk, as you can see here. The cancers that we're particularly interested in trying to prevent the obesity-related cancers are breast, bowel, and endometrium within the BRC. And you can see here that they do count for a relative, the significant number of the cases of those cancers, and actually total number of cases overall. So, as I say, my presentation is going to cover the breadth of particularly our breast cancer prevention lifestyle program. So one element of it is actually trying to establish what the risks actually are in terms of obesity, who's particularly at risk, and then understanding the mechanisms, and I'll explain a bit more why we're interested in that. And of course, as you've already heard, it's all very well known what behaviours we want people to follow, but we need to help them do that. And we've done quite a lot of work in that area about how we can actually try and engage people. So the links between weight and breast cancer are certainly not new, and it's not something that I discovered 20 years ago. In fact, it was 47 years ago that the first published reports of excess weight increasing the risk of postmenopausal breast cancer. And we have made some inroads into this, but we don't have an effective public health strategy to mitigate the effects of weight on breast cancer risk. And of course, in those 47 years, in the UK, the average BMI of women has gone from 25 to 28. We were about 8 kilograms heavier than we were 47 years ago. So we're definitely still going the wrong way. And back in 2005, I was lucky enough to be able to conduct an analysis to actually see whether if somebody had overweight or obesity, if they could lose weight, whether it reduced their risk. And the really good news is that that risk is reversible, which is not a given. And we were able to show that if women could lose even just 5 or 10% of the weight they had gained throughout their adult life, which is where the risk really lies, they could reduce their breast cancer risk by anything between 20 and 40% in our study, and then a couple of other studies have followed since, wearing that out. So we know that we want to help people lose weight, but we also know it's quite difficult. And I'm particularly focused on how we help individuals. Obviously, I realise there's a whole lot of work that we need to do alongside of that in terms of population approaches, but I'm not going to go into that. You need to do the two things together. You can't just do the population approaches, and you can't just do the individual. So something that you might imagine is that if somebody has a familial risk of breast cancer, as significant numbers of the population do, probably about 20%, then you might imagine that lifestyle risk factors aren't really so important for them, because their risk is basically contained in that genetic risk. But an important message is that, and shown in this study here by Hopper, an Australian cohort they looked at with people of different population risk, and also people with a moderate and high familial risk. And this is showing the how they're, if they have a higher BMI, basically the risk of excess weight is proportionally the same across women of whatever their risk, which basically means that because a woman at higher familial risk already starts off with a higher risk, her absolute risk of getting breast cancer is a lot higher if she's overweight. So, and these are obviously a group that we want to focus on. So the high risk people, because we can't, we want to help everybody and give the message to everybody, but we can only really support a certain proportion of the population. So does telling somebody they're at high risk change their behaviour? And I'm sure a lot of people on this session will probably be aware that it doesn't. But I think there is a perception that amongst, in the medical world, that if you tell someone they're at high risk, they're going to change their behaviour. And there are lots of studies that have shown that that isn't the case. And myself and David French did a review of reviews, which showed, comprehensively that if you give somebody information about the genetic risk, or a risk score, something like the Q risk, or even showed them clotting up of their arteries and on visual scans, and don't do anything else, people don't spontaneously change their behaviour. A lot of people need support. And so we were interested to see whether, if women were told they were at higher risk of breast cancer, would they be more likely to join a supportive programme? And this was work we did within the PROCAST study, which is a large cohort study that Gareth Evans and Tony Howell are conducting in Manchester, which is giving women who attend breast screening their breast cancer risk. So we were in the fortunate position of having a population who'd been told they were at different levels of breast cancer risk. And they were invited to a supportive lifestyle programme, either with just breast cancer risk information or also information about risk of other diseases. Now, the two different invites didn't actually end up being different, but the really interesting take-home message from this that we published last year, a couple of years ago, was showing that the higher risk women were more likely to join the intervention, they were more likely to stay with it, and therefore they were more likely to lose weight. So we've got 70% of the women who are at high risk, who the group we really want to help, successfully losing 5% of weight, which, if you remember earlier, reduces their risk, versus 43% in the low risk. So we have some evidence that we can engage women who turn up, go for screening, who are at higher risk with a lifestyle programme. And so we've done some work around how we support them. And even before COVID was thought about, we've done a lot of work for years about remote delivery of weight loss interventions, and remote phone and web is just as effective as face-to-face. We've shown that in a couple of studies, and we've just conducted the family history lifestyle study where we've taken high-risk women and they have followed a weight loss program which is supported by phone calls and an interactive website. And just to make the point that was part of that work was done by a couple of dietitians from the area who signed up for some of the BRC placements, which was fantastic. So, and we're writing this up at the moment. Basically, our remotely delivered weight loss intervention achieves about a 7 kilogram weight loss versus a couple of kilos in the control group. So it's very effective, and now we need to do work about rolling it out. The other thing we've done is, as well as the support, it's obviously important what you tell people to do. And we developed, you may not be aware, we developed, myself and Professor Howe, shown here, developed the intermittent 5-2 diet back in Manchester. Actually in 2005 we started working on that. We've written books, and all the money goes to prevent breast cancer, but there are a lot of other 5-2 diet studies now, and basically the message is it's an effective way for people to, so you diet for 2 days and you eat normally for 5. It's an effective method for weight loss. It's actually not superior to a standard daily diet long term. In the short term it is, but it's certainly an alternative approach, and there are some interesting metabolic signatures with it that we're still looking at. So intermittent diets and phone support are good. So even with all of that, of course, a lot of people do struggle to control their to lose weight once they've already gained it. So what you really want to do is to stop people gaining weight. And certainly for women, most of their weight is gained, their adult weight is gained between the age of 20 and 50. It's before they hit the menopause. And I think, again, there's a perception that weight gain is all around hitting the menopause, and it's not. So I'm very fortunate to have a fantastic dietitian, Mary Peggington, who's doing a PhD as part of the BRC, along with myself and David French. And she has been looking at this issue about how we might prevent weight gain. If you want to know more, she's written this fantastic review, a narrative review about when women gain weight, why they gain weight, and what we might be doing about it. And she's also working up a weight gain prevention app for high-risk women that she's working up, designing with the women at the moment. And so finally, if I've just got a couple of minutes, so we're very interested to understand why weight loss and energy restriction might reduce cancer. Obviously, we've got the observational studies, but I think it's really important to understand why, partly to strengthen the cancer prevention message, because I think a lot of people struggle to understand. I think you can understand why smoking might give you lung cancer, why eating too much saturated fat might give you heart disease, because you can visually see it. But why would being overweight give me breast cancer or any of the other cancers you've seen? So if we can have some underpinning of why it works, I think that's important. We could, we're years behind the cardiovascular field. They've got a fantastic marker of risk and how it changes when you try and do preventative interventions like cholesterol. We don't have anything like that in breast cancer. And so if we do mechanistic studies, we may be able to find that. And the other thing is, at the end of the day, some people can't follow dietary interventions, and we might need to develop drugs. So just to show you, we're currently, as part of the BRC, we're actually doing some work with trying to see the mechanism of what happens when women with obesity go on a very low calorie diet in terms of what happens to their breast and endometrial tissues. These are healthy women, and it's a study that we have a PhD student, Dr. Helen Clark, that I'm doing in collaboration with Emma Crosby and Sasha Howe and others. But basically, it's a randomized trial where obese women at high risk of breast or endometrial cancer are randomized to either a very low, an 800 calorie diet for 3 months and nothing else, or a control group. And at the end of that, we're looking at the effect on proliferation, metabolomics, and they basically have breast and endometrial biopsies conducted at the start and the end of that 3-month period. And there's all, we're looking at stem cells and gene expression in the lab on those tissue samples, as well as a lot of blood samples. And we're following the women up for a 12 months to look at their sort of long-term adherence. So I'd just like to, so sorry, that was a bit of a whiz through. I'd like to acknowledge obviously the BRC and our trial participants who actually volunteer for these crazy studies, either with, you know, crazy 5-2 diets back 15 years ago, or to, you know, volunteer to have breast and endometrial biopsies when they're actually healthy. It's extraordinary. All my team, all the team that work on the PROCAST study, my lifestyle research team down at Wythenshawe, and of course our funders. So thank you.
Thank you, Michelle. That was fascinating, and I certainly have a couple of questions for you later on, particularly around, I guess, the characteristics and profile that you hinted at of the 5-2 diet in particular. But yeah, if you do have any questions for Michelle, please do put them in the chat, and of course we can address them later in the Q&A session. So bang on 11 o'clock, we're ready for our next speaker, who is Elisa Kell, who's a clinical senior lecturer, and she's going to speak to you about her work in dermatology.
Thanks very much, George. I'm just waiting for this share screen to allow me to share my screen. I don't know if Jane can help at all, but it's not giving me the option to share. I'll start my video as well. So good morning, everyone. I'm sure we'll get my slides up in a second. Okay, I think I'm a host now, so I should be okay to. Jane, it won't let me share as it did earlier when we trialed this.
Do you want to send your talk? Have you already sent it? I'll share it.
Okay, just bear with me. So by what I'm going to do quickly, Jade, I'm just going to try and sort that out, and then I'll make a start. I think that's probably best. Just bear with me.
We're happy for you to make a start, or and we could wait.
Or go straight to Sam, possibly.
Or we could move straight to Sam if Sam's ready. Would you mind swapping?
Yeah, that's fine.
I'm very happy to swap, or I can start, whatever's easier for everyone.
Shall we swap just while we get the share screening right?
That'd be brilliant. Thank you.
Yeah. Okay. So a slight alteration to the program, but we'll see Elise later speaking about her work. It's with great pleasure I'm going to introduce the next speaker, which is Sam Kuth. He's going to talk to you about developing interventions to prevent noise induction hearing loss. Sam, over to you.
Thank you. Let me just get my slides up. Okay, can everyone see that? Wonderful. So yes, I'm going to be talking to you today about some work that we've been doing as part of the hearing health theme of the BRC to develop interventions to prevent noise-induced hearing loss. Now, there's been a couple of projects running in the BRC, or Manchester Centre for Audiology and Deafness, looking at this area, and they've been running in parallel to one another. So one's been looking at recreational noise exposure in the general public, and the other's been looking at occupational noise exposure, specifically in musicians. So if we look first of all just at the one in the general public, we've had a couple of different studies under this project. So we've done an epidemiology study to look at the amount of noise exposure, recreational noise exposure in the general public, and ways that the general public have gone about trying to prevent noise-induced hearing loss for recreational noise. We've done a systematic review looking at different intervention studies to try and promote hearing protection use in the general public as well. The quality of those tends to be pretty poor. And we've also done an intervention design study to try and develop an intervention to try and promote hearing protection use in the general public as well. And now, running in parallel to that, we have this occupational project looking at noise exposure in musicians. And very similarly, we've done an epidemiology study to look at the risk of noise-induced hearing loss and tinnitus in musicians compared to other noisy industries. We've done a longitudinal study to look at hearing health in musicians. And very similar to the recreational noise project, we've done an intervention design study and started to pilot that intervention as well. And it's these last two studies that I'm going to be talking to you about today. So just to put everything into a little bit of context, so approximately 37 to 58% of classical musicians have noise-induced hearing loss, compared to approximately 17% of the general public having noise-induced hearing loss. That number varies slightly depending on how hearing loss is defined, but you can see that in musicians this is much higher than the general public. And the thing about noise-induced hearing loss is that it's entirely preventable. And there's three methods that we can use to prevent noise-induced hearing loss, all very simple. The first one is simply turn down the volume at its source. The second is to move away from the noise source to a quieter place. Or the third, which is usually considered the last resort, is to use hearing protection. Now, for musicians, the first two steps here, turning down the volume or moving away from the source of the noise, is not always feasible. So although a last resort, wearing hearing protection is perhaps their only resort. And for that reason, I'm going to be focusing on this particular behavior today. So despite this increased risk of noise-induced hearing loss in musicians, the consistent use of hearing protection devices may be as low as 6% in musicians, so really quite low. And there have been previous interventions to try and promote hearing protection use in musicians, but they've had very limited effectiveness so far. Now, why haven't these interventions worked? I knew someone would eventually use this word in today's presentation, so I'm going to be the first to use it, I think, and that's Isla-Gayet. If you're not familiar with this word, it stands for "it seemed like a good idea at the time." Okay. So what do I mean by this? Well, basically, previous interventions may have been developed without any kind of evidence or without any kind of model of behavior change to try and help develop these interventions. And in the case of the interventions to try and promote hearing protection use in musicians previously, they're mostly based around the idea or whim, if you will, that providing education will promote hearing protection use by musicians. So one particular model of behavior change or framework of behavior change that I'm going to focus on today is something called the behavior change wheel, which is in this the image that you can see here. And there's quite a lot of parts to this, and it's quite complex. What I'd like you to focus on first of all is just the green part at the hub of this wheel. And this is something called the COM-B model. So COM-B stands for capability, opportunity, and motivation, and these are the things that drive behavior. So capability are things that are internal to an individual that drive behavior. So it could be their physical skills and their physical capability. It can also be their psychological skills. So for example, knowledge, memory, cognitive capacity, that sort of thing, that will dictate whether they behave in a particular way. We have the opportunity, so this can be divided into social opportunity, so social norms, stigma, taboo, that sort of thing that can influence behaviour. And then we also have physical opportunity, so these are actual physical barriers in the environment which dictate whether people behave in a particular way. And then finally, as part of this COM-B model, we have automatic motivation. which can be things like emotions and people's reactions to things happening in their environment, which dictate whether they behave in a particular way, and also reflective motivation. So these can be people's goals, their desires, their beliefs, which may influence the way that they behave. Now, this behaviour change wheel has been used in the context of hearing health previously, but it's been more focused on kind of treatment for hearing problems. So, for example, it's been used to develop interventions to try and promote hearing aid use in first-time hearing aid users. But it hasn't yet been used in the context of hearing conservation and preventing hearing loss. So that brings us on to this study. So the first aim of this study was to identify what are the main barriers and facilitators of hearing protection use in a large sample of early career musicians. In particular, we're interested in early career musicians because they're going through a very intensive period of musical training at this sort of stage of their careers. So they're exposed to a lot of noise very frequently, and thus interventions may be very crucial at this particular stage of their career. And once we've identified these barriers and facilitators, the next aim is to use this very systematic approach of the behaviour change wheel to enable us to develop an intervention strategy to promote the use of hearing protection. And then the third aim was to pilot and evaluate the effectiveness of that intervention. So just a little bit more about the behaviour change wheel. The behaviour change wheel provides a very systematic and methodical approach to developing interventions. And it's an 8-step process. Now, I've only got 15 minutes today, so I haven't got enough time to go through all 8 steps. I'm just going to focus on steps 4, 5, and 7. The first 3 steps, just very briefly about understanding what the behaviour is that needs to change. So who needs to do it, when they need to do it, why they need to do it, that sort of thing. Step 4 is about identifying what needs to change. So these are the barriers or facilitators of the desired behaviour, in this case, the use of hearing protection. And I've written something called TDF here. So this stands for the Theoretical Domains Framework. And all you need to know is that this is a way of breaking down the COM-B model even further into kind of slightly more specific parts for us to understand why people behave or don't behave in particular ways. So once we've identified what needs to change, the next step is identifying something called intervention functions. So these are essentially the broad methods that we use in an intervention, and there's 9 of these developed as part of the behaviour change wheel. And then the next thing we want to do is identify the behaviour change techniques. So this is essentially breaking down our intervention functions into its irreducible components, so the smallest parts of behaviour change. And what I mean by that are very specific methods for bringing about an intervention. So how do we do this? Well, we recruited 80 early career musicians from just up the road, the Royal Northern College of Music, and some from the University of Manchester. And we did a very broad, semi-structured interview with our musicians to establish what their thoughts were about hearing loss, what they thought about hearing protection use, and why they used or didn't use hearing protection. And we did a very kind of broad thematic analysis on this to draw out our key themes which formed our barriers and facilitators to hearing protection use. So this is quite a noisy slide, so I'll just take you through it briefly. So the 6 barriers or facilitators to hearing protection use that we identified very broadly were a lack of concern about hearing problems from our musicians, a lack of access to hearing protection devices, the detrimental impact that wearing hearing protection devices has on music listening or performance or enjoyment, which you can imagine is a big barrier for musicians. With social pressures, so a lack of encouragement, stigma attached to wearing hearing protection, and the social norms amongst musicians about wearing hearing protection. We also had discomfort and poor fit of hearing protection devices, such as earplugs, and the affordability of high fidelity. And what I mean by that is very high quality hearing protection devices. And as you can see, what we've done here is we've drawn out these broad themes and we've arranged them according to these theoretical domain frameworks. So these are the the drivers of behaviour. And you'll notice also that some of these themes or barriers, they don't just apply to one particular theoretical domain framework. So in the example I've highlighted here, the impact of earplugs on music listening and enjoyment and performance, this could represent a physical barrier, physical capability barrier for musicians, in that they're not able to perform correctly whilst wearing hearing protection devices. But it can also fit into their reflective motivation. So perhaps for certain musicians, they don't actually use hearing protection devices, but they already have this belief or expectation that wearing them will impact on the way that they listen to music and enjoy and play music. So we've arranged our barriers and themes in this way. And the next step is to identify intervention functions. So I'll just explain what I mean by this. So here's a quote from one of our musicians. I don't think that I need hearing protection for my instrument. And we've assigned this to the theme or the barrier, a lack of concern. And this particular barrier we've put under the combi element physical opportunity. And in particular, we've assigned this to the TDF, the theoretical domain framework, environmental context and resources. The reason we've done that is because musicians aren't necessarily aware of the sound levels that they're in when they're in their rehearsal spaces, and that's why they think they don't need to wear hearing protection. So with the development of the behaviour change wheel, certain intervention functions are specifically linked to certain theoretical domain frameworks. So for this particular theoretical domain framework here, environmental context and resources, there are 4 specifically linked intervention functions. We have environmental restructuring, enablement, training, and restriction. So we could perhaps take any of these 4 intervention functions as a method for bringing about behaviour change. However, what we don't want to do is to use all 4 of these at the same time. This is something called a scattergun approach. And yes, whilst it may be effective in increasing hearing protection use, if it is effective, we don't know which one of these particular elements is effective. And it's important to understand which one of these is causing or driving behaviour change. So how do we go about selecting the most suitable intervention function? Well, we use something called the Appease Criteria to assess each of these individual intervention functions. So this stands for affordability, practicability, effectiveness, acceptability, side effects, and equity. So the intervention that we use must be fair for all parties concerned. So once we've done this, we've applied our Appease criteria to select our intervention function. What we want to do is to select the behaviour change techniques that will bring about behaviour change. So just to remind you, behaviour change techniques are the very specific methods which will drive a behaviour. Now there's a taxonomy of 93 behaviour change techniques. And similarly, when the behaviour change wheel was developed, these 93 behaviour change techniques have been linked to very specific intervention functions. So if I return to my previous examples where we're looking at a lack of concern about hearing loss in musicians, and we've put this down to environmental context and resources, not affording hearing protection use for our musicians. We've looked at our 4 intervention functions, and by applying the Appease criteria, we've decided that environmental restructuring is perhaps the one that's going to have the most traction. It ticks the most boxes in terms of the Appease criteria. Now, there are very specific behaviour change techniques linked to environmental restructuring. In particular, we have providing prompts and cues in our environment. We have adding objects to the environment and restructuring the physical environment. So perhaps just rearranging the way an orchestra is laid out could have some sort of effect on the way that people use hearing protection. Now, again, the same as we don't want to select lots of intervention functions, we don't necessarily want to select lots and lots of behaviour change techniques. We want to try and narrow in on maybe just a couple of these to develop an intervention strategy. So how do we select the best ones? Well, again, we use the same sort of criteria, this Appease criteria, to try and narrow in on the particular behaviour change techniques that we think are going to have the most success. So that's exactly what we did to develop a pilot study. So we decided that the best behavior change technique to focus on was prompts and cues. And based on this, we developed an intervention strategy, which is to provide visual cues to musicians to notify them when sound levels exceed safe limits. So how did we do this? Well, we use this device here, you can see on the left-hand side. This is something called a sound ear, and it's essentially a sound level meter. And when sounds exceed a safe limit, this ear starts to flash red, and musicians know that it's no longer safe in that particular environment to go on unprotected. And the idea is that when the ear flashes, they take their hearing protection devices and pop them in their ears. So with our pilot study, we had 4 of these devices installed in various rehearsal spaces and practice rooms at the Royal Northern College of Music, and we were assessing their effectiveness at increasing hearing protection use in musicians. That was in late January, early February 2020. So I think you can imagine what happened next. Yes, coronavirus came along, and that meant that the Royal Northern College was closed. And so we haven't yet been able to determine the effectiveness of this particular intervention to promote hearing protection use in our musicians. But what we have done is we've been able to identify the barriers and facilitators to hearing protection use in early career musicians, and we've arranged these according to the COM-B model. And that in turn has allowed us to use the very methodical and systematic approach of the behavior change wheel to narrow in on a particular behavior change technique that we think may have some success in promoting hearing protection use in this particular group. So what we're going to do next? Well, when permitted, we hope to restart the pilot intervention study and see if that has any traction at increasing hearing protection use in our musicians, and we'll assess the effectiveness of that and try and tweak that for perhaps a larger scale rollout down the line. But also returning to that other strand of work, the other project that I was looking at the start of this presentation, we also want to look at developing similar interventions for recreational noise exposure in the general public, and what can we do to promote hearing protection use in the general public more widely. Thank you very much for listening. Hopefully that was informative for you. I'd just like to thank my collaborators here in Manchester and in Cincinnati Children's Hospital over in the States, and Jane Ginsberg over in the Royal Northern College of Music just up the road. And also thank you to my funders and to the BRC for supporting this work as well. Thank you.
Thanks very much, Sam. What an excellent talk. And I'm sure people will have questions coming through on the chat. I've seen a couple now, but again, just to remind people, there is an opportunity for full panel discussion at the end of this event. So I'm just conscious a little about time. Elise, are you ready to give your talk?
I'm back. Thanks, George. Let's see. Hopefully the technology will be with us. If not, Jane will help us. So let's see what's... Hopefully you will be seeing my slide show.
We can see it.
Take it back. Let's take it back with all the little bits and bobs. Okay, great. Super. So you can see my slides, which is fantastic. So thank you very much also for swapping around the agenda to allow for the technology glitches. And my name is Elisa Kell, and I'm really delighted to be here today. I'm a dermatologist and a senior lecturer from the Division of Musculoskeletal and Dermatological Sciences. And I have a big clinical and research interest in inflammatory skin disease and the brain-skin connection. So thank you very much for inviting me to participate today. And what I'll be covering is comorbidities and lifestyle behaviors in psoriasis, as well as a few research-driven interventions that are being undertaken within dermatology. So firstly, chronic plaque psoriasis is a chronic immune-mediated skin disease which affects around 2% of the UK population, and more widely 100 million people globally. We know that it occurs in genetically predisposed individuals, and that there are a number of environmental triggers which may either trigger the onset of disease or exacerbation of the condition. And as you can see from the clinical photographs on the right, there are a number of presentations of the condition. By far the most common is chronic plaque psoriasis, which affects 90% of individuals. And if you look at the slides on the top right and the bottom left, you can see examples of well demarcated, very scaly plaques, which is consistent with the chronic plaque form. We also know that there is a substantial physical and psychosocial burden associated with psoriasis, such that in May 2014, the World Health Organization passed a resolution to develop a global report to reflect the public health burden of the disease. Now, these two clinical photographs show a different degree of severity of psoriasis in terms of extent of skin lesions that are involved and the amount of inflammation in the skin. But they also represent a body habitus that we frequently see in patients with moderate or severe disease. And this links in with some of the comorbidities that are associated with psoriasis. Our patients are at increased risk of metabolic syndrome, fatty liver disease, as well as myocardial infarction and stroke. There's also a link between psoriasis and psoriatic arthritis, inflammatory bowel disease as well. And the link between psychiatric and psychological conditions is very well established. People living with psoriasis frequently engage with a number of behaviors, including smoking, physical inactivity, and excess alcohol. And for the purpose of time today, I won't go into great detail about that, but there's some very well-founded reasons why people might engage in such behaviors. And in light of this, Professor Chris Griffiths led an NIHR-funded program grant, which focused on primary care and the identification and management of psoriasis-associated comorbidity. And this grant consisted of many different strands, one of them being qualitative interviews. And you can see here some quotes from patients which reflect their experiences when, for example, going to see a GP about being referred onwards to a dermatologist, or their perception of how two physical conditions, such as angina and psoriasis, are managed in the clinical setting. The impact study also highlighted the importance of primary care-based screening for cardiovascular risk factors. And if we look at these data here, we can see that there are screen-detected episodes of high cholesterol, hypertension, diabetes, and these might have gone undetected if they had not been screened for. And we'll talk a little bit more about early screening towards the end of my talk. Psoriasis is a complex disease with significant physical, psychological, and social impacts. And it's critically important that we look beyond the skin and also consider the systemic nature of the condition. Also part of impact, a motivational interviewing-based training was developed. This again was focused on clinicians adopting a holistic approach to managing psoriasis, and lifestyle management was an important part of the SOWELL study that was undertaken by a number of the colleagues you see listed there, including Liz Cordingley and Chris Bundy. Building on the work done by Impact, together with Chris Griffiths, Chris Bundy, Liz Cordingley, I developed a SOWELL lifestyle clinic hosted at Salford Royal. The model was to include a consultant dermatologist and health psychologist in each consultation using motivational interviewing techniques. And each patient was offered 6 sessions at 4 to 8 weekly intervals. Now, I'm sure that it's quite understandable that when one's setting up a pilot that a number of logistical and practical considerations may play a role in how our service is set up. And these included identifying clinic space, the appropriate support staff, electronic patient record training for those who did not routinely work in the hospital environment. And of course, there's the issue around tariff and having 2 specialists in one clinic. So we audited the first 21 patients who completed a booklet of questionnaires, And these questionnaires include the self-assessment Salford Psoriasis Index. And the Salford Psoriasis Index gives us an idea about the number of interventions a patient has had, as well as the disease severity. The booklet included the Dermatology Life Quality Index, the Hospital Anxiety and Depression Scale, and also the Sleep Condition Index. And what we found is that more than 3/4 of patients had had a high number of interventions. This represents the patients having had at least phototherapy, a systemic treatment, and perhaps also a biologic. There was a wide range of psoriasis severity and quality of life impact, and around 62% reported clinical anxiety versus 1/4 reporting clinical depression. And a vast majority had poor sleep quality. Furthermore, patients perceived psoriasis as a moderate to high health threat and reported adopting a number of coping strategies, including adaptive or maladaptive strategies such as self-blame. Within our clinical audit, we did a small case series to look at improvements noted, and those were noted in the conditions asterisked. We also received very positive patient feedback. And based on this, we are now introducing a new Solwell clinic at Salford Royal, but this will be in the first instance in the virtual format. And we hope then to go to the hybrid form of the clinic. And you'll recall Michelle was saying earlier that the virtual format may be as effective. So we're very optimistic about flexing in this way to the current working environment. Based on the mental health burden, we are going to include a consultant psychiatrist who's had motivational interviewing in this next version of Solwell, and then we will reevaluate the service. But ideally in the long term, we would wish to have a combination of multi-specialty, multidisciplinary individuals in that clinic to support our patients appropriately. So Georgia Lada is one of the BRC PhD students, and she's just recently completed a mental health survey of patients attending the Greater Manchester Psoriasis Service, which is a tertiary service. She began the survey at the end of 2019 and concluded it in October last year. And the work that she has done has underlined that we still have a reasonable way to go in terms of addressing the needs of our patients and the burden of disease associated with psoriasis. We can see in her sample around 213 that there were high levels of alcohol consumption, with around 43% drinking above weekly limits, and also a high prevalence of obesity, more than half the sample having a BMI of more than 30, which compares to 41% for the UK population-based studies for psoriasis. The depression rates were also higher in our sample than the mean prevalence reported in psoriasis, and the suicidality outcomes up to 3 times higher than the UK rates. And therefore, these data support the current model of having the additional psychiatric support or screening in the Solwell clinic going forward. Now, we talked about the importance of early intervention. This was done when Ian introduced the talk and also by the other talks that we've heard. And just as it is very important that we identify the burden of disease for our patients, we should not overlook opportunities to intervene early on in the disease course, since this might be able to prevent morbidity in the long term. So Chris Griffiths has, in collaboration with a number of colleagues, including Richard Warren, Liz Cordingley, and Claire Reid, received Health Innovation Manchester funding to establish an early intervention pilot for psoriasis, the so-called Psoriasis Rapid Access Clinic. And this is based in the tenet of intervening early is a key time, not only from a patient perspective, but also in terms of preventative medicine and overall population health. The clinic recruits from primary care, and patients who are within 2 years of diagnosis have been included in the study. And this is a multi-pronged approach in terms of proactive screening for comorbidities, having specialist team review, and also a so well motivational interviewing approach for lifestyle management. The patients are then stratified into disease severities, and they also have the opportunity going forward to be involved in research as well. So this is a very promising way in which we can approach a chronic disease, and a strong contrast to the traditional model where patients would frequently be managed in primary care for many, many years and wait more than a decade to be referred onwards to secondary care. And the team is hoping to roll this model out to Salford and then further afield and nationally. So what I've covered today is the manifestations of psoriasis beyond the skin, the common comorbidities and lifestyle behaviors that we associate with the skin disease, and also the translation of clinical research to cold-face clinics and some of the hurdles that we need to overcome when putting these types of clinics into practice. Thank you very much for your attention.
I'm unmuted now. Thank you very much, Elise. That was particularly interesting, and again, numerous questions about psoriasis and the interventions. I am slightly conscious again about time, and like I've said, please do put your questions in the chat, and we will have an opportunity to, I think, delve deeper into these areas at the end of the session where we have a panel discussion. But it's now coming very close to 11:35, so if we take a 5-minute break and we start back at 11:40, where we'll hear 2 further talks. So 11:40 we'll restart. Thank you. Suzanne?
Yeah.
Hi, are you ready to share your slides? Sorry, I just thought I'd check. Yeah. Okay.
Okay.
Okay. So keeping to time, and also I'm very much enjoying the presentations, and I'm looking forward to hearing the next two. So I think there's some keenness to get back and hear about them. So what I'd like to do is next introduce Dr. Suzanne Verstappen. She's a reader, like here on the slides, in musculoskeletal epidemiology, and she's going to talk to you today about the predictors of non-adherence to methotrexate in patients with RA, or rheumatoid arthritis. But thank you, Suzanne, over to you.
Thank you very much. So yes, I work at the Center for Musculoskeletal Research, and the presentation today I'm going to present is based on research which was done by Holly Hope, a PhD student who worked in our center and was funded by the BRC. So just a bit of a background around adherence and methotrexate. So methotrexate is first-line therapy for patients with rheumatoid arthritis. So often they start off with methotrexate, either as monotherapy or combination therapy. If people fail, then they start biologic therapies, and some of these therapies will be combined with methotrexate as well. Unfortunately, when patients start with methotrexate, response to treatment is not universal, and about between 28 and 45% achieve remission after 1 year of starting methotrexate. And some of the reasons could be adherence to methotrexate therapy. When we talk about adherence, it's not something that's very new. Already in 1918, there was like a publication about compliance to response to influenza epidemic, and also to the non-compliance of certain public health initiatives. So in this timeline, you see that some of the wording has changed from compliance to adherence, which was defined by the WHO in 2003 as the extent to which the patient's behavior corresponds with the agreed recommendations from a healthcare provider. And actually, that's still the definition of adherence currently used. It's not just the WHO that recognizes adherence. Also, NICE here in the UK has some guidance about medication adherence. And it is also involving patients and physicians about their prescribed medicines and supporting adherence. Within the OMERACT, which is an outcome measures in rheumatology, so there's a big international organization looking at several outcomes. A couple of years ago, a study group started to look at adherence as well, and how it is measured in different trials, and how can we target adherence in studies. So adherence is difficult to measure. And in these graphs, give some examples of ways of measurement of adherence. On the left side, these are more subjective measures of adherence. So these could be questionnaires, like the MARS questionnaire, which is a validated questionnaire. Could be diaries where people have to complete whether they took the medication or not. And these are more objective measurements, like pharmacy refill, so counting the pills that have been used and distributed. Direct observation is probably not something that's done very often, especially not in large epidemiological studies. And then there's the more objective one where people can take out a tablet and that's monitored, or even measuring drug levels in blood. Although these have all advantages and disadvantages. So you can imagine that the questionnaires and diaries are more subjective. But even the more objective ones have one of the problems, which is that even if patients are told by their physician that they shouldn't take the medication, that means that can't be measured in the blood, for example. But that doesn't mean that they're non-adherent because they adhere to the medical advice of that physician. So that's something to keep in mind as well. So what we did is we did a systematic review on adherence, looking also at predictors of adherence and understanding how often people adhere to the medication. So the 3 different searches were done on 3 different databases. In the end, 10 studies were included. there was a huge range between adherence from 59% and even 107%. So over use of medication. In the next couple of tables, these are the associations of some of the predictors they looked at between for adherence. So this table especially looks at the demographic data. There aren't that many significant associations. One study did find that females were less likely to be non-adherent compared to men, but this wasn't simulated in some of the other studies. And otherwise, not many other significant findings were observed. Similar to disease duration or any disease-related factors, there weren't many significant associations between any of these factors and adherence. When looking at some of the more psychological factors, there was some association about looking at the perception of methotrexate necessity and non-adherence, and also about mood in relation to adherence. So overall, there were a few associations that were found. Some were more psychological and less often demographics. One of the problems also with some of these studies were that these were patients with long-standing rheumatoid arthritis. Some studies were relatively small, and there was a lot of variation in the adherence measurements that were used in these studies. So what they also did in only 3 studies actually is trying to understand if there was an association between adherence and clinical outcomes or patient-reported outcomes. So this was only investigated in 3 studies, and there was a small effect size in all 3 studies. So in the first study by Contreras, they found that non-adherent patients who were in remission at baseline were more at risk of a flare than adherent patients. In another study by Cannon et al., that those who were being adherent, so more than 80% of the time they took their prescribed medication, methotrexate, was negatively associated with change in the DAS28 score. And the last study by Wyman et al. Was a small negative association between adherence, and they used the MEM system, so they put with tablets and disease activity adjusted for other factors. So there's not much out there with respect to the association between non-adherence and outcomes in patients with rheumatoid arthritis treated with methotrexate. In other studies looking at in different diseases and with different drugs, there have been associations between non-adherence and worsening of the disease, and also that then of course leads to higher direct costs or indirect costs. So what we wanted to do is look at more detail about adherence in a larger cohort of patients, taking into account a large variety of both demographic, clinical, and psychological factors. So as part of that, we used data from the rheumatoid arthritis medication study. So this is a large observational study in England in which 38 centers participated. Patients with rheumatoid arthritis who commenced methotrexate for the first time were included and followed for 1 year. And about 2,400 patients with rheumatoid arthritis have been included in this study. So we collected lots of data from demographics, so from age, gender, education, BMI, smoking, etc. Clinical data, which include a disease activity score, the DAS28, morning stiffness, several visual analog skills, fatigue, well-being, and also some of the comorbidities which are very common in patients with rheumatoid arthritis. In addition, patients completed patient questionnaires, including patient-reported outcomes, such as work outcomes, the hospital anxiety depression scale, the illness perception questionnaire, beliefs about medication questionnaire as well. And then adherence was measured in another, for which we use weekly diaries. So patients received the diary for the first 6 months and then the 6-month follow-up. And patients were asked to complete whether they took the medication or not. And I give a bit more detail how we measured adherence in the next slide. And finally, of all these patients, we also measured blood sample. We took blood samples in which we could measure inflammatory markers of disease activity. So how did we measure adherence in these patients? So as I mentioned, each of these patients were posted a weekly diary, which they were asked to complete. So patients were asked if they took their medication. If not, the reason for not taking methotrexate. So we defined it as they forgot to take the methotrexate. They had a side effect. The rheumatologist or the nurse told them not to take medication. So that would be according to medical advice and shouldn't be defined as non-adherence or other, and people could write down what this could be. So the rate of non-adherence was a number of non-adherent weeks divided by the weeks they were on drugs, so up until the 6-month follow-up or up until the point they discontinued methotrexate permanently. So non-adherent was defined as having more than 1 week of methotrexate missed against medical advice. And then we also divided it into intentional and non-intentional. So non-intentional is, for example, running out or forgetting to take any drugs. So these are the baseline characteristics. So we started off looking in the first 1,000 patients recruited to the REM study. And of those, about 600 patients completed the diary. This is a very common baseline characteristics of patients who are early rheumatoid arthritis and who start their first medication. So of the patients who were included in this study, only 26 of the patients were non-adherent during the first 6 months. So a relatively low percentage. And of those, quite often it was just 1 week with an average of 2.6 weeks of non-adherence. Of the 26 patients, 71% were intentionally non-adherent and 90% were non-intentionally non-adherent. What's also interesting, what we could look at is that we, of course, patients stick whether they were advised not to take their methotrexate. And in the total, 20% of the patients missed a dose methotrexate as medically advised. So in some of the studies I previously shown in the systematic reviews where they use systems like the pharmacy refill or the MEMS system, these patients are possibly linked as being non-adherent. So when we start looking at the reasons for non-adherence, the main reason for non-adherence were side effects. So when people said they didn't take the medication, it was mainly because any side effects they experienced in the week before. Some had suspected infections, and some were concerned about the general health, and then that the percentage dropped down to lack of effect with a couple of percent. There were a couple of people who reported that they non-intentionally didn't take the medication. For the majority of these patients, they forgot to take the medication. But there was also some percentage of patients who didn't report any reason in this study. So when we looked at the predictors of methotrexate non-adherence, we did first a univariate analysis, which was followed up by a multivariate analysis, in which age and gender were always included. So we found that there was a full model in here, in which disease activity and fatigue measured by the DAS and any comorbidities were associated with non-adherence. But also when we looked at the beliefs about medication, the differential between the need and the concerns was significantly associated with non-adherence. But some of these measures might not always be collected in the clinic, so we also included a pragmatic model, which is shown here with the results, with very similar results. Then we split also the population in those who were intentionally and non-intentionally non-adherent. And again, there were some differences between those who were intentionally non-adherent. So for example, those who reported being non-adherent, there was an association with the illness beliefs about illness perception questionnaire, and especially with focus on those who had a concern about the rheumatoid arthritis. And there was an association with drinking alcohol. Whereas in those who were non-intentionally non-adherent, the associations were especially with the number of comorbidities and the beliefs about medication, again, about the needs and the concerns differential. So there are some differences between predictors of non-adherence in patients who are intentionally and non-intentionally non-adherent. So in conclusion, we can say that there's actually a large variation in adherence rates if you look across studies. Partly this can be explained by the measurements used in these studies. Non-adherence has been found to be associated with worse outcomes, but there's limited number of studies, and it's quite difficult, especially thinking about methotrexate, to evaluate that association. The non-adherence in patients with early rheumatoid arthritis commencing methotrexate for the first time is relatively high, and often patients just miss 1 week. And side effects are the main reasons for non-adherence. When we look at predictors, high disease activity, multimorbidity, fatigue, and those who have concerns about the methotrexate despite a high need for it are more likely to be non-adherent. So how can we use this information now in clinical practice? So understanding these reasons and the predictors of non-adherence will inform medication education in the clinic at start of the methotrexate therapy, could inform future interventions to increase adherence. But once people have started, it can also facilitate the communication between patients and the clinicians or nurses about possible concerns patients may have when they use the methotrexate. And self-management becomes more common for the patients with rheumatoid arthritis, a chronic disease, and adherence could be part of that self-management. So I would like to thank all the researchers and especially Holly Hope, who did all the work for this research, the patients who participated in the RAM study, and the nurses and the rheumatologists who participated as part of the RAM study. Thank you.
Thank you, Suzanne, for a really great talk. And I again, please do put your questions in the chat or wait until the Q&A session later. But a really good talk about understanding the adherence of methotrexate. I think we're going to come to our final talk now, and this is Dr. Ran Wang, who's a clinical research fellow, and she's hopefully you'll be able to share your screen, Ran. Yeah,
is that right?
And we're moving to the respiratory theme, where Ran will be able to speak to us about allergen avoidance and allergic asthma. Thanks.
Thank you very much for inviting me to give this talk. So my name is Ran Wang. I'm a respiratory registrar and currently doing my PhD in asthma based in Withenshaw Hospital with Professor Angela Simpson, Dr. Claire Murray, Professor Stephen Fowler, and Dr. Hannah Durrington as well. My main research focus and interest is actually on novel aspects of asthma diagnostics. But today I will share some past and ongoing work on allergen avoidance in the prevention of allergic asthma. So asthma is the most common chronic respiratory disease in the UK and drives a substantial health economic burden. In the recent years, we have increasingly recognized that asthma isn't just a single disease. Rather, it is a heterogeneous clinical syndrome and is probably driven by different underlying mechanisms as well. So to reduce the burden of asthma, our current research are generally focused on better understanding of asthma phenotypes, achieving earlier and more accurate diagnosis, more effective and personalized asthma treatment, and of course, investigating the preventative approaches in disease acquisition and asthma exacerbation prevention as well, which I'll focus on today. So allergic asthma is one of the most common phenotypes of asthma, and symptoms are typically triggered by exposure to common inhaled allergens, and that including but not limited to pollen, pets, and house dust mite. Allergic sensitization in the context of asthma is most frequently diagnosed with skin prick test or specific IgEs from blood samples. And the significance of these tests are to identify triggers in asthmatic patients and introducing allergen avoidance, including indoor allergen reduction intervention, which we'll talk about later, or removal of pets that patients are sensitized to, which can cause much distress and is rarely complied with, as you can probably imagine. So there are two broad questions regarding allergen avoidance in the context of asthma prevention. The first question is, does allergen avoidance reduces the risk of children developing asthma? And the second question is, does it help reducing asthma exacerbations or severities once they've already had it? So we know that sensitized individuals are at higher risk of developing asthma from our previous work. And we know that early life allergen exposure is associated with sensitization and also asthma later in life. But the question is, can we prevent children developing asthma by keeping the house clean from allergens prenatally during pregnancy and carry on after they're born? So at Manchester, we have the Manchester Asthma and Allergy Study Birth Cohort with more than 1,000 children recruited actually prenatally. It is set out to investigate the risk factors for the development of asthma and allergic diseases. It's originally set up by Professor Adnan Kustovich and then Prof. Ashley Woodcock, Prof. Angela Simpson and Dr. Claire Murray. And this study is still actually ongoing, and the participants now are reaching 21 years of age actually. So nested within the birth cohort is a randomized trial investigating the effect of stringent environmental control in high-risk children. The high-risk children are parents are both atopic. So actually individuals who are randomized to intervention group, low allergen levels were actually achieved prenatally during pregnancy and also up to the age of 3. At year 1 follow-up, we found that the interventional group had significantly reduced the respiratory symptoms compared to the control group. But actually the effect was gone by the age of 3. Interestingly, however, they did also have markedly better lung function with lower airway resistance, which is making it difficult to interpret in terms of clinical benefit. And it is also interesting that children in the intervention group had increased risk of sensitization to house dust mite at the age of 3, despite they actually had a reduced allergen exposure. And we think that there might be several potential explanations around this, including potential loss of endotoxin exposure, which would normally reduce the risk of atopy. And the intermittent exposure to house dust mites when children are outside their home, for example, may result in sensitization, or reduced allergen exposures in early life may reduce opportunities for them to build tolerance. So the indoor environmental control studies generally show very heterogeneous results, but overall there are some evidence of reduction in the risk of childhood asthma. Although the design of the studies and the interpretation of the findings are fairly restricted in each of the studies. The biggest challenge in the domestic environmental intervention is around non-compliance, and the risk of this increases with longer duration of follow-up as well. And you can imagine these interventions are often burdensome to the patient and are fairly expensive as well. So what about secondary prevention? So let's talk about pets. As we previously discussed, one of the common themes in clinical setting is that patients have poor asthma control, but they live with the pets that they're sensitized to. So can pet allergic asthmatics still live with their pets? And what are the evidences? So from our previous work, we know ongoing exposure to sensitized allergen, which is a house dust mite actually, increases asthma severity and hospital admissions due to exacerbations. And we also know from other studies that asthma attacks are more common if patients are exposed to high level of pets allergens to which they're sensitized to. And many exacerbations may be caused by pet ownership amongst the sensitized asthmatics. And this is the reason why we often have serious and a very difficult conversation with our patients in the clinic regarding consideration of removal of pets. And however, and perhaps it is not surprising that it is never being studied in randomized controlled trial. There is only one small study involving 20 patients observing effect of pet removal on asthma control, and it demonstrated some clinical benefits. But despite this, the most effective measure recommended by clinical guidelines is still to remove the pet from home. So you may ask, what are the benefits of keeping pet outdoors instead? So this measure is effective, but even when cats are removed from the house, allergens persist for many weeks. Allergen concentration begin to decrease several weeks after cat removal, achieving levels similar to control houses without pets into the 24 weeks. And what about keeping the pet, but clean the domestic environment frequently using high efficiency vacuum cleaner and air filters? Well, several studies have shown mixed results. While some clearly shows reduction in both allergen levels and improvement in clinical parameters, others fail to link the reduction in allergen levels with clinical outcome. So the failure of some of these studies to show a statistically significant improvement in asthma outcome may in part be because of the intervention was ineffective, or because the patient selection was inappropriate, or both. Some studies have tended to be very small and underpowered. Some intervention studies are extremely short-lived, and therefore there may be insufficient time to show a benefit. Although most devices tested showed some reduction in airborne allergen levels, but actually we don't know what is a clinical significant reduction in allergen levels. And many studies included measurements of lung function or asthma medication as primary outcome. But we know from our previous mite avoidance studies that these are unlikely to be useful outcome measures, and instead exacerbations and hospital admissions may be better outcome. And you may also ask, what about washing pets a bit more frequently? Well, there are some evidence suggesting allergen levels can be reduced after washing, but effects on asthma is not being demonstrated, and actually allergen levels comes back to baseline level really quickly, especially for cats. Generally, there are several challenges around this. Cat and dog allergens are literally everywhere. There are more cats and dogs sharing our houses than children in the UK. And most patients don't really want to give up their pets because they are part of the family. It's not just your own cats or dogs. There are evidence actually supporting that cat allergens are actually present in most homes without cats. School is a site for potential transferring allergens from other households, and if children attend classes with many classmates with cat at home, then they are also at higher risk of asthma symptoms as well. One of the key and major challenges for such studies are correct patient selection. So in these studies, sensitization or allergy is defined by positive skin prick test or IgE blood test. But we know that these does not equate to clinical allergy. Although cat ownership causes increased risk of asthma exacerbation in sensitized patients, the vast majority of pet sensitized pet sensitized asthmatics do not experience an asthma attack. So it's fairly clear that pets removal are important in some sensitized patients, but not others. So our current diagnostic tests are not very good at distinguishing sensitized but asymptomatic patients from truly allergic patients. So this is actually one of our current work as part of my PhD is on developing a novel diagnostic test which hopefully can tell these people apart and hopefully to better inform which patient would benefit from allergen avoidance and pet removal. So over the past few years, our team have essentially developed a novel progenitor cell-derived basophil activation test, which showed quite promising diagnostic value in cat allergic individuals who reacted to cat allergens during inhaled allergen allergen challenge. And this study was in collaboration with McMaster University in Canada. But it is a retrospective analysis looking at blood tests taken within 2 years of the inhaled allergen challenge. And the forecast study is to prospectively test how good this novel blood test is in distinguishing cat allergic asthmatics from sensitized but tolerant patients. And if they do work well, then we could take it forward to use it in patient selection for allergen avoidance studies in the future. This study has been set up actually, but not currently open for recruitment because of COVID, but we do hope it will start soon. I think that's everything. Thank you very much.
Thank you, Ran, and again, a fascinating talk, and it's good to see, I guess, the Manchester Asthma and Allergy Study Maths being used again. I've been familiar with that around work with the Atopic March that was done some years ago, so it's great to see that study being used. Okay, so we've now got an opportunity in the next 15 minutes or so to address any questions. So with this, would it be possible for all speakers to show their videos? Hello. If you have any questions for the panel, then please do. You can ask verbally, but also do show your video. It would be it's nice to see faces when responding to questions. Okay. Are there any questions that people would like to bring forward for the panel? I can bring them through from the chat. I guess I have a question actually, and it has been brought up here, I think, in relation to breast cancer, but in terms of the profile of patients that you're recruiting to your studies, and do they represent all groups? And if not, do you have plans, or are there plans in order to address this? So I can see here there was a question around that for the breast cancer study in particular, and ethnic women. So I was just wondering whether the panel would like to comment on that, about the recruitment to their studies, and whether it is representative of all ethnic groups.
Shall I start, because the question was addressed to me?
Yeah, Michelle, that would be great.
So our studies are not, and we always present our ethnic split in our studies, and I can tell you, certainly for the breast cancer prevention studies and the breast cancer prevention studies, it's around about 5%, and that's not because we don't try and recruit people. It's that our pool of people that come to the high risk clinics are there aren't so many ethnic women. So the problem is before it comes to us. So there is work to do around actually getting certain ethnic groups and different socioeconomic groups engaged in the whole breast cancer screening. And I think I said in the chat that I work closely with the David French and his behavioural team, and they've been doing some fantastic work which has been published about the barriers for breast screening amongst particularly South Asian women. And there's some very simple things that you could actually do you know, regards sort of the leaflets. So I guess the problem, I'm not justifying our you know, we do have a problem with our research, but the problem is kind of higher up the chain. So I mean, we do get a nice, once we get to patients, we also do, I haven't mentioned it, we do a whole load of work with people who've had breast cancer, and in that we do get a much better range of uptakes, particularly amongst socioeconomic groups and ethnic groups. It's, yeah, so I think the problem is engaging people with sort of screening and high risk clinics.
Would anybody else like to comment on recruitment or who they're targeting? No? Okay. I think there was another question here for Sam, actually. And have you considered looking at issues in younger musicians? So this has come from Sarah Croak. So Sarah, if you'd like to show your screen, you're more than welcome to. Hi Sarah, would you like to frame the question for Sam?
Yes, I mean, both my children are young musicians, and there is real disparity around their music education and the emphasis that's placed on hearing protection. So, you know, one of my kids is at their local music service, and nobody has ever mentioned hearing protection to any of the brass bands or the wind bands or any of the ensembles, not to my knowledge anyway, and I've been involved a very long time. And I have another child who's a student at Chetham's, and they do encourage, at least they supply all the children with hearing protectors, but I know from experience and from what my daughter tells me, they're not actively encouraged at every single rehearsal, and the children develop their musical habits during their training. So by the time they end up at RNCM or as early career musicians, there's a lot of unlearning to happen. So I'm just wondering, you focus very much on the early career musicians. That may be an access and an ethics issue, but I'm just wondering if you've considered looking at bringing such interventions in earlier, and whether that can kind of create a better outcome long term.
Yeah, you're absolutely right, and I fully agree. I kind of, in my presentation, had a little bit of a diss about education as an intervention function. That's perhaps not fair, because research has shown that with children in particular, if you provide education as an intervention function, it has increased the use of hearing protection use in this group. That being said, it's only gone so far. So that on its own hasn't made 100% adherence and uptake of hearing protection devices. You mentioned Chetham's. We've had some contact with them, and I think they're now starting to make hearing protection use slightly more obligatory for certain classes. But again, that depends on the tutors or the teachers themselves enforcing that. So it's not just targeting the children, you've also got to target the educators as well. So it's a very broad issue, and there's lots of moving parts that need to be addressed.
Yeah, I mean, I'm quite impressed, certainly as far as, you know, Chetham's is concerned, compared to my local music service where my other daughter goes, that they do annual hearing tests, and they do supply all the children with the ear protectors. But yeah, there is a real peer message that goes along the children that, you know, well, we don't need to wear them, and children tend not to do anything that they don't need to do. So yeah, it's about how you reinforce that message to the children so they get good habits going forward. I really love the electronic display that you're going to trial. Be great to see that in local music service, because that's where you do have typically lots of children in smaller spaces, obviously not at the moment. But yeah, the rehearsal rooms that my other daughter uses, much smaller spaces, typically more musicians. Yeah, it's different atmosphere, but it'd be great to see that put in with younger kids and getting good habits earlier.
Yeah, I fully agree, and hopefully we will at some point, you know, step away from just focusing on early career musicians, and we'll look at later career and child musicians as well. But the interventions that we've developed are specifically for early career. So the Appease criteria that we've used address the issue just for this group. So it might be that these particular interventions that we've developed don't work with these other groups. So we have to assess the barriers and facilitators for each group individually.
Thanks for that, Sam, and a really interesting question. And the use of the COM-B model is certainly a good way to frame it. I'm just looking through the chat. Elise, there was a very quick question for you, I think from Sarah Kitson, which I can see that you've responded to in terms of the setup of the clinic. But I mean, I think there's a focus here on what interventions are you instituting for your patients with cardiovascular risk factors that you see in your clinic. Is that something you'd be able to address?
Yeah, thanks, George. Yes, so part of the way we address it is with the screening. So, you know, with blood tests, for example, the demographic profile of patients in terms of BMI, for example, and all patients will have those routine measures done. But I think, as others have alluded to before, it is very important that we measure and capture these data, but then we need to go that step further in terms of how do we encourage behavior change so that we can address those factors, because it isn't, you know, as we've discussed today, it isn't sufficient to simply say to patients your cholesterol is high or you're overweight and you need to lose weight. So it's very much a focus on screening and picking up the issues and then having an approach to focus on those. And that's where the So Well Clinic comes in, because it gives that space for us to address these important factors, and that's time that we wouldn't necessarily have in the tertiary service, and also wouldn't necessarily have the health psychologist in the tertiary service either. So I hope that's gone some way to answering that.
Thanks, Elise. I had a quick question for Suzanne, and it was really interesting to hear about the reasons for non-adherence to methotrexate, and you gave a hint of how you'd like to take that forward in terms of how it would frame medical education and the communication. Is that something that are those the next steps that you have taken forward from the study, and are they being implemented now?
There's also another study within our department where they've developed an adherence assay, so measuring methotrexate levels in blood by James Blewett. And he's doing some further research into interventions about adherence. So that's going to start as well. There have been other studies at MRI looking at adherence to methotrexate. And I know that the National Rheumatoid Arthritis Society, they developed a self-management package. And part of that will also talking about medication and adherence as well. So there's a couple of things that are ongoing, looking at some of these interventions.
Thanks, Suzanne. And I think I'm not so sure if it was clear for everybody then. So you might want to come closer to the microphone. I think it sounds a bit echoey. Sorry, I didn't want to interrupt because I did hear most of it, but thank you. Are there any further questions for the panel? Jane?
Hi everyone, thanks so much for your talks today. Just obviously we're kind of coming to a close, just seeing if you've got any final thoughts or your kind of top tips on learning or who to contact, the next kind of steps for certain people that might want to collaborate, say. So if you've got any kind of tips or ideas for collaboration, please could you share with the group? Thank you. Sam, do you want to go first?
I don't really have any top tips or anything, but I'm thinking about a question that I saw pop up in the chat and I hadn't actually addressed it. I think it was from Rory Shepherd, and he was asking whether the behaviour change wheel can be applied elsewhere outside of hearing health. And yes, it has been very widely applied. Smoking cessation, obesity. I've got the book here. This is basically my Bible that I go to very commonly nowadays, and they use an example of increasing hand washing behaviour for nurses on hospital wards. So yeah, it's really very broad. So if people are looking at kind of developing these sorts of behaviour change interventions, that's a really good go-to place. And if people do want some help or advice on that, I'd be happy to help them with that.
Elise, do you want to go next?
Thanks, George, or thanks, Jane, as well. So yeah, again, not necessarily top tips. I think what has really struck me, as it always does when we have these events where we have the ability to listen to colleagues from other specialties, is there's so many areas of overlap on things we're working on. And so I think there's enormous opportunity for us, to consider those areas of overlap. And, for example, with my question about the cardiovascular risk factors, there might be an enormous part of that so well model we set up that could just be adopted to another disease area and prove useful, and vice versa, for me to learn from others. So that's my first thought. And then I think just secondly, it's just about us always just being mindful about the preventative approach. And I appreciate today's very much been focused on lifestyle, but as we've alluded to in many ways today, that those behaviors are founded in years of habits. And so the ideal is for us to try and intervene as early as we can, so that the focus isn't on undoing the habits and addressing the burden of morbidity, but perhaps being more preventative. So I feel that's a really important fact that's come from hearing everyone today. Thanks, Jane.
Thanks, Elise, that's great. Suzanne, do you have any final thoughts?
I think similar to Elise, I think especially with adherence, it plays a role in every disease, every patient taking any medication, and how do we measure it, what's the best way to measure it and understand it. And interventions might be very different as well for those with a chronic disease compared to somebody with an acute disease. Multimorbidity plays a role, polypharmacy, etc. So I think learning from each other about how is adherence in other patients groups, and how can we develop better interventions, education programs, and that would be really useful to share that information across different teams.
Thanks. Rand, would you like to go next?
I just found it extremely educational for myself, because obviously I'm still learning at the moment, and particularly that book, the Behavior Change Wheel book. I think I'll probably have a read, because I think in the world of asthma, non-compliance to medication is a huge problem, I think if we can solve that, we'll probably solve a lot of problems in asthma, to be honest. So it's really, thank you very much for inviting me to talk today.
Thanks for joining. Michelle, would you like to go next?
So I guess I'd echo the comments about how we really do need to work across different disciplines. A lot of my interventions have started off in diabetes or cardiovascular disease, and there's no reason why they can't be applied. We don't have to, obviously we need to tailor things, as Sam's so eloquently described, but you don't need to start from scratch. And just on that point, so obviously the life course is really important, and I think we do need to start intervening earlier and preventing the behaviours that prevent disease. But also, because we're trying to I'm trying to prevent cancer, but also a number of other diseases. People don't just get one condition, and also they're not particularly necessarily worried about the condition we think they might be worried about. And for about 10 years now, I've been trying to get funding for a multiple disease prevention intervention. And the problem is I can't go to CI UK, I can't go to Diabetes UK, I can't go to the British Heart Foundation. So I went to the NIHR, and they just thought it was a step too far. So if anyone's got any ideas about how we could, so this idea that and we've demonstrated it, you can give people multiple disease risk, and then different things will appeal to different people. And at the end of the day, the behaviours we're trying to address will reduce the risk of all of those things. So that's a real challenge. And the other very quick point is that, some people, giving education by itself, some people will just run with it. Probably about 10% of people that I get in the clinic that I can just give a leaflet to will go away and do it. But obviously there's a significant number of people who need different levels of support. So it's personalising that support. We don't need to do the same thing for everyone. And if somebody's got some very clever ways of working out how we triage people or help them with choice about different dietary strategies, because we tend to, in studies, we allocate people, which is a nonsense, because different people will be suited to different things. So those are the issues about personalising our approaches and cutting across different diseases.
That's great. Ian, I know prevention is going to be a key theme for the next BRC. Do you have any final kind of thoughts or updates around that as well?
It strikes me that what Michelle's saying is really, really interesting and important for us to think about, because there are two threads. There are two threads here. One around how some lifestyle interventions have multiple effects downstream. So if you were in a dementia meeting, if you were in a cardiovascular meeting, a diabetes meeting, a rheumatoid arthritis meeting, some of the things we've heard about today fit very nicely, and you've seen that across. And I think when we try to develop more connectivity across the BRC, let's say someone is developing a large cohort to do a particular intervention to aim at a certain thing, then that's an opportunity for us to think about what else could we add to that to understand that. And the two big areas that's in is lifestyle interventions around, let's say, weight and stuff like that. But then the second thing is around the adherence. You've seen a lot of different groups trying to get adherence going, whether it's asthma, arthritis, adherence to hearing defenders, etc., etc. So I think and there are common threads, and Sam outlined very nicely the common threads and thinking around that. So I think if we can think about cross-theme type working on these types of areas, I think we all learn from each other and we get techniques from one area that apply beautifully across into something else. So I think this is why these kind of seminars are so important, because you learn a lot and you learn how big a deal it is in another area of medicine, and you think, well, these things must be fundamentally interconnected, as they say.
Okay, thanks, Ian, for that. And I think that nicely rounds up the seminar and the training session for today. I'd like to thank all the speakers, Ran, Elise, Samuel, Michelle and Susanna. They were fantastic and really interesting talks, and I think the cross-learning, certainly I've learned a lot today, and particularly the methods I think are common, so it's really been nice to hear them. I'd really like also to thank Jane. Jane, thanks for organising this. It's been a really, really good event, certainly a teachable moment, and we really will look forward to hearing from others the next training series. So please do keep an eye out for training events across the BRC. For those of you that are PhD students or fellows, we're currently putting together, hopefully, like a mini training camp that will be hosted in the summer, that will give you an idea about how to transition in the next stage of your career, but also an idea of how you can put together a grant application. So please do keep an eye out for those future training events, and we hope to hear from you soon. And thank you, Jane. Bye-bye.
Bye.